Good afternoon. Myself Dr. Trisha Arora, Assistant Professor from the Department of Obs and Gynae. Today I will be presenting a topic Hyperemesis Gravidarum. Okay, so on introduction, vomiting is a symptom which may be related to pregnancy or may be a manifestation of some medical, surgical, gynecological complication which can occur anytime during pregnancy. Medical could be intestinal infestation, could be UTI, could be hepatitis, could be ketoacidosis or diabetes, could be uremia. Surgical causes could be peptic ulcer, appendicitis, intestinal obstruction, cholecystitis, and gynecological causes could be twisted ovarian tumor, red degeneration of fibroid. Depending upon the severity, vomiting related to pregnancy state is classified as simple vomiting of pregnancy or hyperemesis gravidarum of severe type. Simple vomiting, patient complains of nausea and occasional sickness on rising in the morning. Slight vomiting is so common in early pregnancy, may occur at other times of day, does not produce any impairment of health or restrict the normal activities of the women. Features disappears with or without treatment by 12th or 14th week of pregnancy. Management of simple vomiting is assurance, dry toast, biscuit, avoidance of fatty or spicy food. Vitamin B1 supplementation 100 mg daily, anti-emetic drugs, trifluoperazine, promethazine or ondansetron can be used. Hyperemesis gravidarum, excessive vomiting of pregnancy, incapacitating the day-to-day activities and or deteriorating the health of the mother is called hyperemesis gravidarum. Incidence, marked fall in incidence, now a rarity of in hospital practice. Reasons, due to better application of family planning knowledge which reduces the number of unplanned pregnancy, early visit to antenatal clinic, potent antihistaminic and antiemetic drugs. Hyperemesis gravidarum causes dehydration, oliguria, loss of skin elasticity, weight loss, electrolyte imbalance, metabolic acidosis or alkalosis. Etiology, mostly limited to first trimester, more common in first pregnancy with tendency to reoccur again in subsequent pregnancy. Has got a familial history, young age, low body mass, motion sickness or migraine. More prevalent in herediform mole and multiple pregnancies. More common in unplanned pregnancies. Theories. Hormonal, high level of serum human chorionic gonadotropin, estrogen, progesterone and altered immunological states are considered responsible for initiation of the manifestation which is probably aggravated by neurogenic factor. So psychogenic, it probably aggravates the nausea once it begins. Dietetic deficiency, probably due to low carbohydrate reserve as it happens after night without food. Deficiency of vitamin B6, vitamin B1 and protein may be the effect rather than the cause. Decreased gastric motility and allergy is also found to cause nausea. Clinical course. Early, vomiting occurs throughout the day. There is no evidence of dehydration or starvation. Late, vomiting is increased in frequency with retching, oliguria, epigastric pain, constipation. Signs, features of dehydration and ketoacidosis, dry coated tongue, sunken eyes, acetone smell to breath, tachycardia, hypotension, rise in temperature, also oliguria, epigastric pain, constipation. So investigations, urine analysis, quantity, dark color, high specific gravity with acid reaction, presence of acetone, occasional presence of protein and bile pigments, thyroid function and electrolytes. Biochemical and circulatory changes, ophthalmoscopic examination, retinal hemorrhage, detachment of retina, ECG, abnormal serum potassium level, USG, complications, neurological complication, Wernicke's encephalopathy due to thiamine deficiency, pontine myelinolysis, peripheral neuritis, Korsakoff psychosis, stress ulcer in stomach, esophageal tear, jaundice, conversion, renal failure. Management. The principles in the management to correct vomiting, to correct the fluids and electrolyte imbalance, to correct metabolic disorders, alkalosis and acidosis, to prevent the serious complications of severe vomiting. Hospitalization, admitted with same diet and drugs used at home, the patient improves rapidly. Fluids, oral feeding is withheld for at least 24 hours after the cessation of vomiting. During this period, fluid is given through IV drip method. The amount of fluid to be infused in 24 hours is calculated as total amount of fluid, approximately 3 liters, of which half is 5% is dextrose and half is Ringer's solution. Extra amount of 5% crystalloid equal to the amount of vomitus and urine in 24 hours is to be added. Drugs. Antiemetic drugs, promethazine 25 mg or prochlorperazine 5 mg may be administered twice or thrice intramuscularly. Vitamin B6 and doxylamine are also safe and effective. Hydrocortisone 100 mg IV in the drip is given in case with hypertension or intractable vomiting. Oral method prednisolone is also used in severe cases. Nutritional support with vitamin B1, B6, C and B12 are given. Nursing care, sympathetic and firm handling of the patient is essential. Social and psychological support should be extended. Diet. Before the IV fluid is omitted, the foods are given orally. At first, dry carbohydrate foods like biscuits, bread and toast are given. Small but frequent feeds are recommended. Gradually, full diet is restored. Hyperemesis progress chart, vitals, urine output, electrolytes, improvement, subsidence of vomiting, feeling of hunger, better look, normalization of biochemistry, disappearance of acetone from breath and urine, normal pulse and blood pressure, normal urine output. That will be all. Thank you.